All right. It's time for the second to the last chapter lecture. This is chapter 14, Psychological Disorders. So here we go. First, we need to define some terms. Prevalence. Prevalence is the rate or frequency of finding a disorder, any disorder, in a population. Generally, with mental disorders, we find that it's somewhere between 1 and 2% of the population having any given mental disorder. Diagnosis. People misinterpret what diagnosis means. They think that you just can pull it right off the top of your head, but you can't. Diagnosis means distinguishing between. This simply means that there are a lot of disorders that have very similar symptoms. And because of that, we have to know how to distinguish between disorders that have similar symptom sets. Etiology. Etiology is not the science of consuming food. It is the science of studies of causes of diseases or disorders. Many disorders we know have some very strong genetic underpinnings, and other disorders we think are more associated with environmental influences. And finally, prognosis. Prognosis is our predictability of how much better someone's going to get after the onset of a disorder. And it is very unlikely that anyone will ever do any better than they did pre-morbid or before illness. Okay, what we're talking about here is abnormal behavior. This means behavior that is on the extremes of the bell-shaped curve. Abnormal behavior, specifically in reference to mental disorders, can be defined by three specific criteria. First is deviance, how different the behavior is from the norm. This usually means way down on the lower 2% of the bell-shaped curve. The second criteria that we use to determine abnormal behavior is subjective or individual distress. How upset or distressed someone might be by their the disorder that they're experiencing. And this is a very important thing. For some people, we find that they think their disorder's all right. They think it's a good thing. They like it. Among people who are extremely psychotic and may have a schizophrenic disorder, this could be something that they say they are not distressed by their suspicions of other people. For example, their paranoia. Because they don't believe they have any. They believe their suspicions are real, and therefore they're not distressed by what we would refer as symptoms. They're distressed by what they believe is real. So we have to take into account what that means. So subjective or personally determined distress. And the third characteristic is maladaptive behavior. This is the individual with a phobia of closed-in places. And most of these examples I give you are real examples from people I've worked with over the years. This would be the example of this would be an individual who has a phobia of closed-in places, so they won't get into an elevator, and yet they have extremely bad knees, and they walk up 20-some flights of stairs every day. Never leave the office during the day. Eat upstairs, don't go out to lunch with anyone. Bottom line is, they never leave the office until it's time to go, because they can only take one flight up and one flight down during the day, because they're not able to go up and down in an elevator. That's maladaptive behavior, or a person with obsessive compulsive disorder who has extreme anxiety over germs. And so they stand outside a door waiting for someone to walk in, pretending to play with their phone, until that person reaches out, opens up the door, and then they're able to elbow their way into the door so they don't touch the door at all with their hands because of their fear of germs. So, these are examples of maladaptive behavior. Okay? Now, let's talk a little bit now about cultural norms. What's considered what's considered abnormal behavior is often considered abnormal because of society's definition of it. An example of this starts with the Diagnostic and Statistical Manual, which we'll talk about. The Diagnostic and Statistical Manual is sort of the Bible of diagnoses of mental illness. When it first came out in the 1960s, its first edition, it's now 7 editions since then. For example, homosexuality was stuck away as a diagnosis, a mental disorder. Stuck away with the paraphilias. These are the illegal sexual behaviors like voyeurism, pedophilia, exhibitionism, etc. Well, it was found pretty quickly that that didn't seem to be an appropriate place, and so it was slowly moved out over time. It was moved out to a lesser category, and then from that lesser category to a category that really isn't much of anything but a place to put certain behaviors into, and then finally made its way out of the Diagnostic and Statistical Manual, because society's perceptions of homosexuality changed over the years. So, cultural norms in society have a lot to do with whether or not we consider certain behavior abnormal behavior. Okay, well, let's talk about disorders. We're going to start talking about the big three. The big three are the 3 categories of disorders in which we find the largest percentage of people with disorders. I'm doing a lecture. And these are anxiety disorders, mood disorders, and psychotic disorders, most specifically, just schizophrenia. So let's start with anxiety disorders. Gee, what do you think the major symptom of anxiety disorders is? Well, yes, you guessed it. It is anxiety. What's anxiety? Anxiety is a physiological and emotional reaction to stress. We're going to talk specifically about 4 anxiety disorders. And by the way, the category of anxiety disorders is the category in which we find the largest number of individuals. So more people experience anxiety disorders than experience any other category of disorders. Let's start with GAD, Generalized Anxiety Disorder. Now, these 2 chapters, 14 and 15, that we're doing here, these are my favoriteest 2 chapters. Why? Because this is what I do all day long. I diagnose people, and I find treatment modalities that can help people get past their disorders. So, generalized anxiety disorder is an anxiety disorder in which an individual experiences anxiety, significant anxiety, or anxiety attacks in response to a number of different environmental stressors. So this could be someone who doesn't like driving in heavy traffic, doesn't like being in closed-in places, doesn't like speaking in public, and doesn't like meeting new people. So that would be a handful of different situations in which that person experiences anxiety. They experience anxiety attacks, not panic attacks. Panic attacks are part of panic disorder, which is another anxiety disorder, similar to generalized anxiety disorder, but not as severe. Now, just because someone has an anxiety attack, that does not mean that that person isn't uncomfortable and in a great deal of distress. They're in a lot of distress. So we don't minimize generalized anxiety disorder. We simply say that it's not a panic attack, and a panic attack is extremely severe, very severe. But anxiety attacks are quite uncomfortable. Shallow breathing, some sweating, increased heart rate, clammy hands, etc. These are anxiety attacks. Next is obsessive-compulsive disorder. Well, obsessive-compulsive disorder has 2 characteristics: obsessions and compulsions. An obsession is an intrusive thought, a thought that the individual does not like to have. It's very disturbing to the individual, anxiety-producing to the individual. A compulsion is a behavior that the individual can do that will make that anxiety go away for just a little while. So this is an individual who has a great deal of anxiety about germs. And so what do because they have an anxiety about germs? Well, they end up washing their hands a lot. And every time they wash their hands, their anxiety abates. But it comes back again. Now, there are numerous different types of obsessive-compulsive disorders. These obsessive-compulsive disorders, hoarding, for example, is a type of obsessive-compulsive disorder. I once treated a man who had a checking disorder. That meant that he had to check things over and over many times. Some of you, in an attempt to get some of the extra credit may have watched the movie As Good as It Gets and have watched Jack Nicholson have to do things 5 times. His number is 5, and so he has to repeat certain behaviors 5 times for him to stop feeling anxiety. So, different types of obsessive compulsive disorder, but they all share the same basic set of characteristics. Post-traumatic stress disorder. Some of you are writing your papers about post-traumatic stress disorder. Well, post-traumatic stress disorder, the first criteria for diagnosis is very simple. An individual has to have experienced an event that would cause significant distress in almost anyone. In other words, that's the trauma. Post-traumatic stress disorder has a variety of different symptoms. Flashbacks, nightmares, emotional numbing, social distancing, a great deal of problems in social relations, increased distress around anything that reminds them of the trauma. In working with combat veterans with post-traumatic stress disorder, we sometimes find that they don't like the 4th of July. All of the bangs and booms and pops do a pretty nasty job of reminding them of very horrible feelings. Their overall arousal, meaning that center portion of the brain in the midbrain that includes the cingulate gyrus, the basal ganglia, the hypothalamus, and the amygdala, easily and quickly just fires up at the influence of external stimuli that might either literally or even symbolically remind an individual of their trauma. So I work with individuals who have survived childhood abuse. Often, if those individuals are just having to be around people who control a lot, that can be very triggering, because all abuse has a certain amount of loss of control associated with it. Many individuals who, as adults, have loving, caring partners, spouses, just every so often in consensual sexual activity with their loved one, they will begin to experience these types of symptoms, simply because it has to do with sex and there was sexual abuse in their trauma. So these are very hurtful things. The last of the anxiety disorders that I'd like to discuss with you are phobias. A phobia is an irrational fear of a person, place, object, situation. And there are many different types of phobias. There are simple phobias. So fear of spiders, arachnophobia, is a simple phobia. It's about a singular stimulus, and that's it. Whereas you can have a very complex phobia like agoraphobia. Agoraphobia is the fear of leaving one's home, fear of being out in open spaces, fear of being in large groups of people, and people will stay in their homes interminably. I worked with a woman who actually stayed in her home for 3 straight years, never left. You can get a lot of stuff delivered to your home. And literally, when I saw her, her family drug her out of her home forcefully. I didn't tell them to do that, But they brought her to my office and dragged her out of her home. And, they asked if I could treat her, and I said, well, sure. And we set an appointment, but she might not come. And I said, well, she has to come. And, of course, to them, that meant we were going to drag her out. So they put her in between two of them in the back seat so that she couldn't get out, and drove her to the office. And that's how we started our treatment. She's actually doing quite well now. These anxiety disorders, well, they can be treated in many different ways, but that's for the next chapter. That's chapter 15 that talks about different treatments. There are biological underpinnings of anxiety disorders. There are just people in this world that are more prone to anxiety reactions than other people. And it seems to be just how they're born. Or it could have to do with environmental influences, or a combination of both. There are your anxiety disorders. There are many others, but those are just the ones that I'm going to discuss with you. Let's talk a little bit about mood disorders. A mood disorder is a disorder of your happiness, your pleasantness, your enjoyment of life. And so here we're talking about either extremely high moods or extremely low moods. We're talking about either manic episodes or depressive episodes. Now, we're not going to talk about the disorders yet, but what we are going to talk about is the difference between a depressive episode and a manic episode. And you'll see that there are parallels. In a manic episode, a person has an euphoric mood, so extremely high mood. In depression, the person has a dysphoric mood. They're down, blue, sad. The person who's manic is up, high, and often agitated. It's not necessarily a pleasant feeling. In fact, the worse the manic episode gets, the worse the feeling is for the person. Sleep disturbance. Individuals that are manic, these individuals don't sleep. They don't sleep for days and days and days, maybe even weeks. And of course, as we discussed earlier, lack of sleep on top of a disorder that causes mania in the individual makes it all the worse for them. In fact, it gets worse and worse the less sleep they get as the manic episode gets worse. On the other hand, with depression, now, in a manic episode, they don't want to sleep. They don't feel tired. Depressed people feel very tired, but often can't sleep or sleep all the time. Appetite disturbance. People who are depressed, very, very minimized appetite. Or if they are chronically depressed, their appetite might be just kind of constant. Whereas the manic person, they have no thought or concern about eating for forever. Days and days and days. And then all of a sudden they'll eat voraciously and eat everything around them. And then they just keep going. Individuals, let's see, in a manic episode, highly agitated, depressed, irritable. People who are in a manic episode are socially stimulated. They're talking to everybody at 100 miles per minute. The person who's depressed, very socially isolated. The person who's manic has energy out the wazoo. They can go and go and go and go. The person who's depressed, exhausted, heavy, and tired all the time. Cognitive processes. The manic person, their cognitions are super fast. but not accurately fast. They make large leaps of bizarre logic, but their mind's working at 100 miles a minute. On the other hand, the depressed individual, everything grinds down to a horrible halt, and their thinking is compromised. This is attention, concentration, memory, reasoning, etc. So, I can keep going down the list of depressive symptoms, but there's no need to. You get the idea. Very depressed or very manic. Now, there is either bipolar disorder or unipolar depression. Unipolar depression means the person only becomes depressed and then perhaps comes up to a normal state. They don't ever go up into a high or a happy. The bipolar individual tends to vacillate between extreme high highs and extreme low lows. So you have bipolar depression and you have bipolar mania. All in the same disorder. Okay. So let's talk about major depression. Major depression means that a person has to have all of these symptoms, or at least enough of these symptoms that I've mentioned, and a few more, to a certain level of severity. Now, what causes this? What causes it is what happens in the synapse with both serotonin and norepinephrine. Serotonin is not accepted well by the receiving dendrite. There's lots of serotonin out there, but the dendrite's receptor sites don't receive it well. Those receptor sites are dull on the dendritic ending. That's one cause of depression. What serotonin does is it balances our mood, keeps us from going too up or down. Norepinephrine, on the other hand, is our contentment and happiness chemical. This makes us pleased, happy, enjoying. Not extreme, just feeling okay, feeling good. But the same thing happens in norepinephrinergic synaptic sites. The receiving dendritic ending with its little receptor sites on it, that receiving site, those receptor sites are dull, and the norepinephrine goes out, and just like with the serotonin, gets sucked back in too quick by its reuptake, and therefore it's not out there long enough. On the other hand, with a manic episode, these are individuals that have way too much norepinephrine. Excessive norepinephrine causes manic episodes. So we know what causes them. It's very biological. But these biological components or these biological processes can be caused by genetic predispositions, or they can be caused by environmental influences, or they can be caused by a combination of both, which is often the case. A new science over the last 10 years or so called eugenics is the idea that we have to have environmental stressors impinging on biological predispositions to bring them to life. And that's probably the best explanation for these types of disorders. Okay, so let's talk about a few. Now, there are many different types of major depression. For example, there's major depression with melancholia. That means the major symptom, the one that shows itself the most, is deep, deep sadness of that individual. Whereas there are other types of depression where they meet the number of symptoms, but the main thing that sticks out is, what's another one? Major depression with mood congruent psychotic features. That means the person is so depressed that they're starting to have strange delusional beliefs about how horrible a human being they are, that they're devil spawn and they deserve to die, and things like that are just absurd thoughts. But the depression is affecting their thoughts so deeply that they start to have self-persecutory beliefs at a very intense level. So those are just two types of major depression. There are quite a few others. SAD, seasonal affective disorder. This is where people get depressed during the dark months of the year. A lot of this we've found is sometimes associated with vitamin D levels, but even when we treat with vitamin D, these individuals will still become very depressed during the dark winter, fall months. And that being the case, it's interesting to watch that these individuals will only go on antidepressants during those dark months because they're fine during the lighter times of the year. There are other depressive disorders, but there's also a low-grade depression. Just like you have a low-grade fever, a fever of 100.3, it's there. It feels cruddy, but it's not bad enough to stop you from doing anything. You just feel crummy. Well, there's a low-grade depression, and this is called dysthymia. Dysthymia simply means that the individual has all the symptoms of depression, but from normal, they don't go way down like a very deep depression. They only go somewhat down, and then they'll come up periodically, and then go somewhat down. But they never drop way down into a major depression. This is called dysthymia. Okay. That's enough for depressive disorders. Let's talk about bipolar disorders. Bipolar means, really, what bipolar means is that an individual has had to have had at least one major manic episode. There is no bipolar disorder without the existence of a manic episode. In fact, there is a type of bipolar disorder called bipolar disorder manic type, where the individual only goes up into manic episodes and never drops down into a depression, which makes it very hard for us to get them to take their medication because they think these ups are great until they get into horrible trouble. Some of the trouble people get into in manic episodes, it's pretty nasty. Indiscriminate spending. I know one woman who in a week's time spent $35,000 on junk, just ran up credit cards. She bought her husband 17 different fishing poles because he needed a specific fishing pole for each kind of fishing. Well, they took back as much as they could, but still ended up with a $10,000 credit card bill. People make dumb decisions in manic episodes. People in severe manic episodes end up waking up in the morning with someone that they really did not want to wake up to. They are hypersexual because they're hyper everything. So lots of bad decisions can be made during manic episodes. The most common bipolar disorder is bipolar disorder manic depressive type, which means that every couple months they go up into a manic state and then they go down into a depressive state for a little longer usually, and then they come back up to normal, and then after a few months they go up into a manic state and then back down into a depressive state. You can almost set your clock by it. As I said, there are numerous other bipolar disorders. There's bipolar 1, which is what I've just got done describing. That's bipolar 1. And then there's bipolar 2. Bipolar 2 is also referred to as hypomania. Not hyper, hypomania, meaning less than a full manic episode. So here's normal, here's a full manic episode. A hypomanic episode might be up here. It's not super bad, but it's still there, and you can tell it's there. These bipolar 2 disorders, the individual goes up into that hypomanic state, and they generally go down into depressive states too. Usually the depressive states are much lower than the hypomanic state is high, which makes them not really want to be treated for their hypomania, because that feels good. And it doesn't get up into the psychotic arena of a hyper manic state. So, but they still make a lot of bad choices and just have a rough time. Just as in the depressive disorders, there is a low-grade depression, we also have in mood disorders a low-grade bipolar disorder. So this is called cyclothymia. Now what that means is, here's normal, here's dysthymia, here's bipolar 2, hypomania, here's major depression, here's full-blown manic episode. A cyclothymic disorder goes up some, comes down some, comes up some, comes down some, just on either side of normal. All of the symptoms are there, but they're not sufficient enough to call it a full bipolar disorder. So, this gives you a little bit of an idea of what mood disorders look like and what cause them. And by the way, the neurotransmitter that causes depression, as we mentioned, serotonin and norepinephrine. Well, guess which two also cause anxiety? You'd be right, serotonin and norepinephrine. Now, what is the worst symptom of all of these mood disorders? That is suicidality. And this is why we have to be so very careful with these individuals, making sure that they're not suicidal. And if they are, we have to do what we need to do to keep them from doing something that might harm them. We can't let them take their lives. Okay, so next lecture we're going to be talking about schizophrenia, symptoms and different types. We're going to be talking about a whole bunch of other disorders too. We'll talk more about a few, but we'll mention a great many. Such as eating disorders, dissociative disorders, certain childhood disorders, substance-related disorders, dementia-related disorders, personality disorders, sexual disorders, somatoform disorders, etc. So we'll talk about many of those along with schizophrenia. We'll also talk a little bit about the definition of insanity. And we will see you next time. Good luck. Keep working hard. You're almost done.